Good evening. This is Dr. Bernstein with our May 2018 teleseminar. Before we get started, I want to give you the usual warning, namely that the answers that I give to your questions may not apply directly to you. I intend them to be general answers that help the listeners at large and be of interest to most of the listeners. And there's no way that I can be certain of the answers I give you because to treat a patient, you need to have a full history and a physical exam. And clearly, I can't do that for everybody. So I'm guessing at things, but they're educated guesses. And the idea is that you should learn how to make educated guesses too. Before we begin, I want to remind you that I've screened the questions I'm willing to answer. These sessions are meant to be a free benefit for people who have read my book, Diabetes Solution. If you have not read it, you should take a look because almost all the questions are answered in the book. Unfortunately, those that are clearly and readily found in the book, I'm not going to answer, except if they're very impassioned and of an emergent nature. It's sort of disturbing for me to see how little is known about diabetes amongst the people who have asked questions but have not read the book. Whether they're doctors, patients, nurse educators, it's as if the only place that you can really get good information about diabetes is to read my book. There's so many myths out there, so many bizarre diets, magical solutions, and so on. It's really hard to believe that people with a potentially fatal disease know so little about it. Before we start answering questions, I want to let you know that we had an article published on May 15th, 2018 in the New York Times about a study we did that was published in the journal Pediatrics a week earlier. This was a study of a group from type 1 grit, which I mentioned before. That one is ONE, type ONE grit, which is a Facebook group that uses my book Diabetes Solution as a guide. And what the study found was that with 2 years after switching over to the methods described in my book, we had not only steady, near normal blood sugars, in fact, according to the ADA, very normal blood sugars, but far less hypoglycemia, far less ketoacidosis, almost non-existent. Major changes in the well-being of the patients, new growth amongst the children, et cetera, et cetera. So this appeared in the Science Times, which is a section of the New York Times on May 15th, 2018, and may still be probably found on their website. The actual article would be found on the website of the journal Pediatrics. Now to our first question. I'd like to get your input on wound healing for type 1 diabetes. It seems my wounds heal slower and tend to leave scars. Is there anything you could recommend besides reducing my hemoglobin A1C? Well, this is a difficult question for me to answer because I served in the wound care clinic of a major medical center for 30 for 30 plus years, and I was director of the clinic for about 7 years. So there's so much to know about helping wounds to heal. I'll try to take uh, the most important things. First of all, if you have an open wound, you should not apply hydrogen peroxide or any form of iodine. Both these agents destroy the macrophages that facilitate healing. Those are white blood cells that help the healing process. The topical antiseptic that I prefer is called gentian violet, G-E-N-T-I-A-N. You can get it from your pharmacy if they don't have it in stock. It will do several things. Coat wounds and therefore act sort of as a band-aid to keep them from being exposed to further pathogens. If the wounds are wet, it will tend to dry the wounds. It is staphylocidal. The usual pathogen that affects the skin is Staphylococcus, and this stuff kills Staphylococcus. It serves multiple purposes. The one big hazard is that if you get it on your clothing, it cannot be removed. There's no cleaner who can get gentian violet off your clothes. It's a deep purple color. Another tip is to be very fast in caring for the wound. You don't wait to see what's going to happen. You clean it off right away, and you apply whatever the appropriate treatment is. And I can't tell you for every wound what the treatment is going to be. Many people and many physicians prescribe bacitracin ointment, which is nothing more than a hypoallergenic petroleum jelly. It's nice for keeping a wound moist, but it's unlikely to kill infectious organisms. The antibiotic ointment that we prefer is mupirocin, which goes by the brand name Bactroban and several other brand names. It's a broad spectrum antibiotic, but there's potential problem with that. You don't want to use it for more than 2 weeks because it'll kill most of the organisms on the wound. But those that survive after, say, 2 weeks are going to be resistant, and they may be resistant to other antibiotics. So the usual hazard with broad spectrum antibiotics in general is to be very careful and not use them excessively, not use them too often. So the gentian violet would be preferable in many situations to using even the mupirocin. Another tip is to keep, if the wound is not bleeding, you want to keep pressure off it because by pressing on a wound, you compress the capillaries that bring in new blood to heal the wound. This is a major problem at many of the wound care clinics I've visited, where there are foot wounds on the bottom of the foot, and the clinics do all kinds of treatment for the wound and then have the patient go out and walk, putting pressure on the wound so that it won't heal. So the wound has to be protected from pressure. If it's on your foot, there are special shoes, special cast that can be modified to take the pressure off the wound site. But even when modifying them, there are tricks. You don't what I used to do was put felt pads inside the cast boots, but you cannot, say, cut a circular hole in a felt pad because you'll be pressing on the wound from the outside all around it, acting like a tourniquet, preventing blood flow in. So I would make U-shaped cuts in the felt to take the pressure off the wound so that blood could still come in and heal the wound. So there are many tricks. It's a sensible but complicated business to properly treat wounds, and many of the centers I visited, as I said, are not doing proper jobs. My cortisol levels were recently checked by my endocrinologist, and the reading was significantly higher than the top end of the scale. Is stress the reason why I experience such wild swings in my blood sugar levels, despite less than 30 grams of carbohydrate a day? I've been a type 1 diabetic for 30 years and have followed your diet for 15 years. Well, one wonders, is he just following the diet, or is she also doing everything else that we recommend in the book, including proper use of insulin and dealing with things like gastroparesis? Now, it is possible that stress can cause erratic blood sugars, but I question whether most people are experiencing such extreme stress that they'll always have wild swings. Rather, I would expect that someone who's been diabetic for 30 years has gastroparesis. And we have a whole chapter in the book devoted to gastroparesis. And for people who are doing everything right, except deal with the gastroparesis, that's the likely reason for wild blood sugar swings. So I suggest that you read that chapter. There are medications for treating it. We use liquid diets. There's a whole collection of approaches to the treatment of gastroparesis. Can you compare the relative pluses and minuses of Tresiba insulin versus Levemir? The major difference is that Tresiba lasts longer. For most type 2 diabetics, I find that they can get away with taking it only once per day, whereas with Levemir they may have to take it twice a day. For type 1 diabetics, both Levemir and Tresiba usually must be taken twice a day. Now, I have early type 1s who are still in the honeymoon period, where we've caught them early enough that they can get away with Tresiba once a day, and usually a very small dose. But if you've had type 1 for a long time and have burned out your beta cells because your blood sugar is not well controlled, then you probably need Tresiba twice a day. And in my case, not only do I take it twice a day, I take a bedtime dose, and my morning dose is about 3 or 4 hours before I arise in the morning. In other words, I take my morning dose in the middle of the night because of the dawn phenomenon. And most full type 1s have to take the Tresiba twice in the middle of the night. But that also applies for the Levemir. The Tresiba does a better job. I can't think of any. The one potential disadvantage to the Tresiba is it's probably harder to get. Not all pharmacies or insurance plans will cover it. The manufacturer does have coupons that will pay the insurance copayment, but it will not cover it if the insurance pays nothing. So essentially, the one disadvantage to Tresiba is it may be harder to get. It may even be more expensive. Is it wise to use regular insulin for meals, but Humalog insulin for corrections of high blood sugars? Well, this person, I'm answering the question even though he or she did not read the book, because that's exactly what we recommend. The one catch with using Humalog to treat high blood sugars is that it's twice as powerful as regular. Not only faster, but it's twice as powerful, which means that if you only need a small dose, it's going to be hard to measure. To give you my personal example, 1 unit of regular will lower my blood sugar by 60. 1 unit of Humalog will lower my blood sugar by 120. So what do I do if I want to lower my blood sugar by 15? I can't unless I use diluted Humalog. I can estimate a quarter of a unit of regular, but a quarter of a unit of Humalog will still lower me by 30. So I would use diluted Humalog if I wanted to use a faster insulin. And indeed, I use diluted Humalog for many of my patients. My blood sugar is 2 to 3 times a day over 200 milligrams per deciliter, but not for a long time because I take insulin and bring it to a normal level. But this blood sugar scares me. My doctor says there is not a problem when blood sugar is high for a short time, but every day my hemoglobin A1C is always good, maybe because my sugar is often 50 to 60 milligrams per deciliter. Well, if you're getting, this could be a type 2 diabetic, probably has not read my book, because the book does indicate that blood sugar variations might be potentially more long-term hazardous than a steady high blood sugars. So I suggest you read my book, and it could also be that this person is taking insulin and is on a high carbohydrate diet. I just don't know. But I say read the book, and if you're type 2 diabetic and not overeating, it should be possible to get normal blood sugars and level ones. I don't agree that it's okay to have high blood sugars for part of the day every day. I've been following a low-carb, high-protein diet and recently developed a kidney stone. It was not pleasant. Could the low-carb diet be a cause or contributing factor for this? No. In fact, my kidney stones began when I was about 22 years old, long before my low-carb diet. I was on an ADA diet in those days, and I've been making kidney stones ever since, and more of them when I was on the high-carb diet than on the low-carb diet. Kidney stones, I believe, are inherited. They do run in families, although no one in my family that I know of had kidney stones, but I have patients who come from families of stone makers. Do you know why it sometimes takes my Novolog an hour to work when I take it 15 minutes before my meal? I have now started taking it an hour before, and it keeps my sugar more level. Should I just move to regular insulin like you recommended in the book? Well, here's someone who actually read the book, and do what it says in the book. The regular gives much more predictable effects. It's also easier to measure because it's not as potent. And that's basically it. What do you consider industrial-sized doses of insulin? Well, I would say probably about 1.5 to 2 times what a non-diabetic, your size, your weight and height would be making. Now, how do you know what a non-diabetic makes? You don't. There was I can only think of one study that was published on this subject, and that was reported in an endocrinology textbook published maybe 40 years ago. So, that said that I think it said 150-pound person makes something like 25 to 30 units per day. So if you're taking, if you're not overweight, that's a non-obese person. If you're not overweight and you're taking 50 units a day, you're probably taking an industrial dose of insulin. If you're overweight, on the other hand, you're insulin resistant, and a non-diabetic, similarly overweight, would be making a lot more insulin than the 25 units per day, perhaps. I have a son of 14 weighs 38 pounds, recently diagnosed with type 1 diabetes. We started a low-carb diet. He is not using insulin. He sometimes raises his sugar level until 140 after meals and then goes down. He is between 70 and 100 most of the time. Do you recommend using any basal insulin, and how do I measure the amount he needs? Well, you read my book because it tells you how to estimate insulin doses. I would certainly recommend that his blood sugars be normal all the time, by whatever means you need to accomplish this. And I might add that I have early type 1 diabetics who are taking insulin, who are taking Glucophage, which is the brand name for metformin, and sometimes even who are taking Avandia. We do whatever we can to keep the blood sugars in kids in the 70s 24 hours a day. Why so aggressive? Because we want to preserve the beta cells. And elevated blood sugars are toxic to beta cells. And if you can preserve the beta cells, you have a disease that's much easier to treat. You have a disease more like type 2 diabetes than like type 1 diabetes. And we've had a number of patients, and I believe members of type 1 grid also have experienced this preservation of beta cell function. Extremely important if you could do it. When our article came out in the New York Times, I got a phone call from the husband of a patient whom we caught early 30 years ago, maybe it's 32 years ago. And she's still on half the amount of insulin that she would be injecting if she were matching what a non-diabetic her size made. In other words, we caught it early, we worked aggressively, and we preserved her beta cells for over 30 years. So that family is very grateful for the aggressive care. Now, another thing that you could do for your son is use diluted regular insulin for those of your meals that cause blood sugar increases. You might want to use very small amounts of Tresiba insulin. Might need only a half a unit once a day, all I know. Again, little tiny things, but used aggressively. What do you think of the work of Dr. Jason Fong and fasting in regards to decreasing insulin resistance and losing weight for type 2 diabetics? Well, you have to beware of anybody who's selling a product. Now, I don't know anything about Dr. Jason Fong. I don't know if he sells a product, but I'm willing to bet that if he's pitching a certain kind of a diet or fasting or a regimen on the internet, that there's a very good chance that he's selling something. So you look at his site, and if he's selling something, I warn you, beware. I've had patients who followed some of these diets that are out there on the internet, and what usually happens is they lose some weight, and then when they get off the diet, they regain it rapidly. But what happens is they lose both muscle and fat when they go on the diet because they're leaving out protein. And then when they go back off the diet on their prior high carbohydrate diet, or even if they go back on a low carb diet, they gain the fat back rapidly, and it's hard to gain the muscle. On page 190 in your book, Dr. Bernstein's Diabetes Solution, 4th edition, it says the protein content of meals is completely up to you, provided you don't take insulin and don't have a digestive disorder. And he asks me to explain this. Could you clarify? I probably should not have said that. What I meant was that insofar as blood sugars are concerned, I like initially when I start a patient on a diet, I guess at what I think the patient might be needing. And I show him samples of plastic foods that contain that amount of protein. And I say, would this amount make you comfortable? No, it's too much. You'll feel full. Or no, you'll be hungry if you only have this amount. They decide, the patient decides, based on looking at the samples, how much he's going to eat. That's how we started off. Now, if it looks like he's not going to be getting enough, but he says that he'll be full if he eats more, I might want him to have snacks. The point that I made in the book was that the initial guesstimate is based upon what a patient would like to have. And that usually is what they need. It usually works out very nicely. On occasion, I have to change it. But usually, again, it's because the patient has said to me, I'm still hungry. I'm not getting enough, or just the opposite, I'm getting full. I am 67 years old. My blood sugar is 116 to 125 in the morning. I don't take any medication, only diet. What should I do? First thing you should do is read my book. And although the ADA would say that your blood sugars are in the normal range, I would say, first of all, what are your blood sugars after meals? They could be much higher after meals, and that might be where we would start addressing things. And of course, in my book, the first thing we do is cut the carbo in the diet. There may be still require medication to cover the meals. Then we have to look at what happens when you're fasting. If you don't eat for a day, do you still have high blood sugars? Or if you go up overnight, even if you've not had a big meal near bedtime, maybe you need some basal medication to cover the fasting state overnight. So go to the book, and it goes into all of these things. I have the inherited lipoprotein small a syndrome. The only, and all of his lipids are in the normal range, except apparently for an elevated lipoprotein small a. And the only change I made between two tests, he had two tests. It was higher on, I think he went on a low carb diet, but I'm not sure. But he had two tests, and they differed by maybe 20%. And he's wondering why there's such a difference. Well, first of all, the specimen for lipoprotein small a is very sensitive to temperature. I think it has to be frozen. I don't recall the details, but it's very dependent upon the handling of the specimen and can vary from time to time, both because of the handling of the specimen, but also because it might change from time to time. If you have a very high blood sugar, about a high liposmall a, let's say it's 175, and it goes up to 210, percentage-wise, that's not a big change. That sort of change, fluctuation can be expected. There are other lipids that you could look at if you're worried about heart disease, such as triglycerides, HDL. Don't waste time or money looking at total cholesterol level or LDL, because those are no longer considered heart disease risk factors. But many doctors and many endocrinologists swear by them, even though the large-scale studies, including the latest Framingham, remove them from the risk factor list. To work on the LP small a, there are some supplements that supposedly reduce it. Also, if you're female and menopausal, taking estrogen can lower the LP small a. Or if you're female and had your ovaries removed, and that's why your LP small a is elevated, estrogen replacement can lower the LP. 60-year-old female, newly diagnosed pre-diabetic, with A1C of 7.3. Now, 7.3 is an average blood sugar of something like 190 milligrams per deciliter. That's clearly grossly diabetic. I don't know what kind of doctor told you that you were a pre-diabetic. I'm not sure why I'm not diagnosed as diabetic. Well, you're smarter than the doctor. Without medication, in 3 months, my A1C is 5.3% by diet. So this person cut her carbo apparently and got her A1C way down. It's only slightly elevated, an average blood sugar of 112. Food consumption is 16% carbs, 83 grams. I'm slowly cutting back on carbs to reach a blood level of 83. Well, what should I do when I get dizzy by cutting carbs? First of all, you should read my book, Diabetes Solution. And it'll tell you to check your blood sugar. If you're getting dizzy and your blood sugar is low, then it could be from cutting carbs and cutting carbs too rapidly. And the book warns you. It says if you're used to a blood sugar of 112 and you rapidly bring it to 80, you might get symptoms that feel like hypoglycemia. Whereas if you bring it down more slowly, you're less likely to get these symptoms. So read the book, and my first suggestion is check. Now, many people with type 2 diabetes also not only have inadequate amounts of insulin, but are still making considerable amounts, but the insulin doesn't respond appropriately to blood sugar. The beta cells don't respond appropriately. So sometimes you may start to make insulin for a meal, but even when your blood sugar drops below normal, you may still be making insulin and going too low. That's a hazard of early type 2 diabetes. And that's one of the reasons why the disease is frequently treated with multiple small protein snacks. And that's mentioned in the book also. Type 2 for 30 years on insulin. Began strict adherence to your plan in 2015. And after 2.5 years, I now show a serum C-peptide present. 2 years ago, C-peptide was 0. Based on your own experience with patients, have any patients had beta cell regeneration healed enough to go off insulin? No. Well, I've repeatedly cited the case of one person, and that was not a patient of mine, he was a friend of mine who had rapidly gained 100 pounds by eating a lot of carbohydrate many years ago. And he got the pharmacy to give him insulin. In those days you could do it. And he taught himself, long before my book, long before I became a physician, he taught himself how to inject insulin. Was taking 100 units of insulin a day, went on a diet, low carb, lost 100 pounds, no longer had high blood sugars, was able to stop the insulin. It's the only case that I know of. I've not seen it with any of my patients. I've seen preservation of beta cells by catching the disease early and keeping blood sugars normal. Is there any connection between high protein intake and increased cancer risk? Not to my knowledge. Now, there have been articles blaming certain processed protein foods, like, I guess, salami and sauce, things. How significant studies are, but not strictly because of protein. It's because of the processing that claims were made. 1, 0. My son, 13 years old, diagnosed with type 1 with A1C of 8.9. He is taking Novo Rapid and Levemir. After 2 months, his A1C is 6.2. That's an average blood sugar of about 148. Is it okay to take vitamins to preserve his beta cells? Again, we're at the problem of parents looking for magic. If he lives in a cold climate where you don't get much access to sunlight, probably makes sense to check his serum D3 vitamin D3 level, and if necessary, give replacement. That's not going to change his diabetes. To my knowledge, there are no vitamins that are going to cure his diabetes. You should read the book and keep his blood sugars normal if you want him to be a long-term survivor, and if you want him to grow. I'm currently taking Tresiba and Novolog, and someone recently introduced me to Afrezza. That's an inhaled insulin. I find that bolusing with Afrezza can be tricky, as I'm not used to insulin peaking so fast, but the convenience of inhalable insulin is appealing. With Afrezza, it seems I'm having to bolus after meals instead of before in order for the peak to be timed concurrently with meal digestion. Do you have any recommendations for switching from Novolog to Afrezza? Well, as a rule, may not apply to everyone, I'm against Novolog for meals, for most meals, for most people, and I'm against Afrezza. But there is one situation for which Afrezza was intended, and that was for type 2 diabetics who experience a high blood sugar and want to bring it down rapidly. These are people who are obese and are insulin resistant, so that the amount of insulin you get with Afrezza, which is considerable, will have a relatively small effect, and their own insulin will eventually do the job, but you give them a little boost with Afrezza, a little down boost with Afrezza, you could get their blood sugar normalized rapidly. So it would be used for making corrections in type 2 diabetics or insulin resistant. The big theoretical problem with Afrezza is you don't know how much you're getting from one dose to the next. You're inhaling it, and the amount you're inhaling it through your mouth, the amount you get in a puff is going to vary with how well you puff. It's going to vary with any allergens you're exposed to, with any upper respiratory infections, with probably the ambient temperature and so on. So you're going to be getting doses that are uncertain, but if you're depending on your own insulin too, you just use this as a fill-in and let your own insulin do the rest of the job. So it means trial and error experimenting, and what size dose would you get for a given blood sugar level, et cetera, et cetera. And the chances are if a type 2 gets a high enough blood sugar to require a correction, it's because they're eating too much carbohydrate. So it would be a lot better to follow our book, low-carb diet, and use medications that keep things level. I'm going to be trying Afrezza because I'm curious, and I like to experience things myself if I'm going to comment upon them, and I'll be trying it in my office with witnesses just to play it safe. I've had type 1 diabetes for over 30 years. This is a survivor, trying to adjust to a low-carb diet. For me, the duration of our insulin is too long even when I have a high-protein meal without carbs. Instead of using R with a protein meal, what do you think about taking Apidra 1 to 2 hours after the meal to match the protein? Well, Apidra is faster than the R, so that certainly would not be the insulin to take. R is the slowest of the rapid-acting insulins. I have occasionally seen people where the R was not fast enough. Here you want something to be slower. Now, there's one little trick that you can do, and that is to add a small amount of NPH insulin to the vial of regular insulin that you'll be drawing from, and that will slow down the regular. You will have to shake the bottle of regular before each use to resuspend the NPH. How much to put in the bottle is up to experimentation. I have no idea, and it's very surprising to find that R is working too fast. Now, it could be that your digestion is very slow, and maybe you have gastroparesis. After 30 years of type 1 diabetes, that's what I would expect. So I would think that you should get an RR interval study. We've published, I believe, in one of our videos how to do this. Your doctor should be able to do it. And that's to make a diagnosis of gastroparesis. Or you can just assume you have gastroparesis and then try some of the medications we recommend to confirm it. And there's a whole chapter on gastroparesis in my book. Treatments include using liquid meals to speed up the absorption. So my guess is that you have gastroparesis, that you probably should be having liquid meals, whether they're blended meals or pre-made commercial liquid meals like Atkins shakes and whatnot. That's a matter of trial and error. But read the chapter on gastroparesis. My 3-year-old daughter has type 1 diabetes 3 months ago. What is one piece of advice you would give to me, the mother, for cooking for my newly diagnosed daughter while still letting her be a normal kid? This is a very common problem with parents, where they want the kid to be normal and ignore the effects upon growth, upon longevity, and et cetera, caused by high blood sugars. The normal becomes the important thing, and the well-being of the child becomes secondary. I just encountered a situation like this with a mother where they were going to spend a large amount of money for a distant vacation for the family and did not want to spend any money on diluted insulin to keep the blood sugars normal. I've seen this over and over. Before I became a physician, I was active in lay diabetes associations, and again encountered parents who learned very little about the disease and wanted to get involved in fighting for a cure instead of taking proper care of their children. You could read my book, Diabetes Solution. It has some sample diets in it. There's another book called Diabetes Diet that actually was written by the mother of a type 1 son, and the mother owns a gourmet restaurant, and he gets gourmet meals for each meal. Or if you go to Type 1 Grit, you can see what some of the parents are doing in the way of delicious meals for their kids. But to think that your kid is normal in the sense of being without diabetes and trying to make her think that way, I think that's a mistake. You can be super normal, and I know of many kids who outperformed their classmates athletically, intellectually, and so on, but have diabetes and are taking good care of it because they're not pretending that they're normal in the sense of being non-diabetic. I've been fasting now for 8 days. No food at all, just water. My blood sugar is 95, and in the morning 100. Where is all the glucose coming from? How is it possible to lower my fasting glucose to 83? Well, I would suggest that you read my book. I assume that you haven't been diagnosed as diabetic, but if your fasting is 100, it could be that you're mildly diabetic. You could check your hemoglobin A1C. If it's over 5, you probably have very early diabetes. And you could also take a look at your blood sugar after meals. That's the most important time to check. So I'd suggest, aside from reading my book, the first thing you do is check your blood sugar after meals. Type 2 for 5 years. Were you able to reverse your kidney problems? Well, if you read my book, you'd know that they were reversed many, many years ago. Probably more than 50 years ago. So that my kidney function today and 50 years ago was probably normal. Now I have to think to count just when. I started normalizing blood sugars around, say, 1972. And by 1975, the proteinuria was normalized. So 75 is not 50 years ago, 43 years ago. Okay? I am a type 1 and have recently started following the keto eating plan. Now, just hearing that, I start getting worried because most keto eating plans are, number 1, not adequately low in carbo, number 2, grossly inadequate in protein, and therefore dangerous. I can't say, I don't know all of the keto eating plans, but I've seen patients who are following many of them over the years, and some of them were in pretty sad shape. I find that even after a month on keto, my liver keeps dumping glucose basically all day long. I did some research and think that going on metformin may help my situation of constant high blood sugars. Do you have an opinion on whether that might be the best course of action? Well, first of all, what's happening, if you are not eating carbohydrate, if you're really not eating carbohydrate, where are you going to get blood sugar from to keep your muscles going? And let's say the ketones are keeping your brain going. And the ketones only are made after you stop converting your muscles to glucose. So if your blood sugar is going up, you're still converting muscle mass and possibly other proteins in your body to glucose. If you read my book, you'd know this. It's called gluconeogenesis. And you may need a low carbohydrate diet and medication. And You picked metformin. For all I know, you may need injected insulin. I don't know. If you're going after metformin, I recommend that you go after the brand Glucophage, which in my experience is probably, unless the generic metformins have changed, the Glucophage is probably twice as potent as the generic metformins. But read my book. What's your opinion on Januvia? I am currently taking with metformin and concerned about risk of pancreatic cancer. Well, Januvia is what's called a DPP-4 agonist. It destroys the enzyme that destroys GLP-1, which is an enzyme, a hormone made by the intestines when you eat a meal. And it has a near zero effect upon blood sugar. I don't think it's been associated with pancreatic cancer, but GLP-1 agonists, and this enables GLP-1 to go up, have been associated with pancreatitis. So the Januvia possibly may be associated with pancreatitis, but since it does almost nothing for blood sugar, I don't see any reason for taking it. There may be some rare individuals where it has a small effect, but I've tried it on my patients and seen no effect. I'm interested in trying Jarrow Formula's Alpha Lipoic Sustain 300 and Evening Primrose Oil to reduce my doses of injected insulin. In your book, you warn against R-alpha lipoic acid if you have a family or personal history of cancer. Well, I don't warn against any particular antioxidant. The R-alpha lipoic acid is a potent antioxidant, and we now know that as cancers grow, they go through stages where oxidants help them to grow and proliferate, and they go through stages where oxidants hinder growth. And depending upon what stage you're in, taking an antioxidant can be beneficial or harmful. And since you probably have no way of knowing what stage you're in if you have cancer, I would say that it probably makes sense not to fool around, or to speak to your oncologist if you have cancer. If you don't have cancer, I doubt that this will do harm, but I doubt that it's going to change your insulin dose. You could try it and see. It's been supposedly used successfully in very high intravenous doses to treat neuropathies. But it's so much easier to have normal blood sugars and use that which we know for sure reverses neuropathies than to go after something magical and hope. Type 1 for 50 years. This is another survivor. I gained weight in the past few years, 245 from 180 pounds. In past few weeks, I've gotten A1C to 5.3 from 6.9, with goal of 4.5 using Tresiba and Humalog. Again, I certainly wouldn't use Humalog. And this person, diabetic for 50 years, probably has gastroparesis, and Humalog is much too fast in insulin for people with gastroparesis. Humalog for meals. Would you recommend generally for long-term type 1 Victoza for weight loss to help to deal with carb cravings? Well, if you read my book, you'll see that indeed we do recommend it. It doesn't work for everybody, and many people find that after a while they become tolerant of the Victoza. When that happens, we switch them to Byetta and maybe to other GLP-1 agonists, and we sometimes rotate the different ones over time as tolerance develops. Not everyone develops a tolerance. Some people find that the Victoza helps curb their overeating indefinitely. So it's certainly worth trying. But I would read you the book about treating your diabetes and your likely gastroparesis. Recently diagnosed with advanced proliferative retinopathy. Pursuing aggressive treatment with a retinal specialist while I also work to bring down blood sugars. My question is how to bring them down safely. A1C currently 8.5, which is a pretty high average blood sugar. Endocrinologist wants them down to 7.5 in a month, but I worry that's too fast. Well, Ernst Chantelau in Dusseldorf discovered a number of years ago that diabetic patients who had proliferative retinopathy and simultaneously elevated IGF-1 levels in their blood, insulin-like growth factor number 1, would get more severe retinopathy if they rapidly brought down their blood sugars. So the first thing I would recommend is that you have your doctor check your IGF-1 level. And if it's elevated, I would say that you bring down your blood sugar slowly. But 7.5 is not, an A1C of 7.5 is not a normal blood sugar and will certainly predispose to proliferative retinopathy and also macular edema. 7.5 corresponds to an average blood sugar of about 190 milligrams per deciliter, which is more than double normal. So if your IGF-1 level is normal, I would think that you could bring down the blood sugar as rapidly as possible. I've had several patients with macular edema who brought their blood sugars down rapidly. They didn't have high IGF-1, and they reversed the macular edema. If I take metformin and glimepiride, can it make me have a kidney infection or a urinary tract infection? I doubt it very much, but number one, I would not recommend glimepiride, which is a sulfonylurea, which both burns out beta cells and has been shown to be associated with high cardiac risk. And I would recommend, if you're taking metformin, that you switch to Glucophage, the brand. I might add, I don't even know who makes Glucophage. They never give me samples. I've had no communication with the manufacturer because I can't get samples. But I do know that it's more potent than the generic. You don't have to worry about kidney infection from either of these. I'd suggest you read my book and that your doctor read my book so they learn how to properly treat diabetes. What is a safe and effective way to lead a newly diagnosed type 1 diabetic toddler, 2.5 years old, onto a low-carb diet? First of all, as rapidly as possible. read the book. And two, the whole family should be on the low-carb diet, not only because other people may be at risk for diabetes, but they will be less likely to get obese, less likely to develop heart disease, and atherosclerosis, et cetera, et cetera. So read the book, normalize blood sugars, and switch the diet suddenly, not gradually. When people are switched gradually, they retain the craving. And as I mentioned before, I have a friend who's been promising to go all the way to low carb for the past 40 years or so, and has never made it because he tried to do it gradually. Stop. Well, thanks for listening to this teleseminar. We will next be broadcasting on Wednesday, June 27th, 2018. Look forward to seeing you then. Have a good month. Enjoy the summer. Winter in Australia.